Good afternoon. Thanks for hanging with me and being here to wrap up the session. I'm going to talk about, so I'm with Asthmapolis, now known as Propeller Health, and I'm going to talk about a program we've done that really falls outside kind of the big body of work we do commercially with health plans and payers, and describe this effort in Louisville, Kentucky. How many of you know about the company and what we do? I want to kind of figure out how much time to spend on of setting the context. Okay, we'll spend some time. So asthma, huge issue, despite all we know about the disease and how to treat it. It's not well managed in the US. Majority of folks don't have the disease under control, which means a lot more days with symptoms, a lot more healthcare utilization than really should occur with appropriate therapy. And huge costs, regardless kind of where you fall in the socioeconomic continuum. If you're in Medicaid managed care, you're spending a bunch of unnecessary time and dollars in medical attention. If you're aggressively managed in Kaiser, same situation. So obviously, huge opportunity to take people who are doing poorly, help them do better, and then effectively as a business share in those savings, but also build up a valuable public health data layer that hopefully kind of gets us on a path of actually knocking down prevalence through primary and secondary prevention. So I used to work at CDC in asthma and respiratory disease. Pretty depressing place from a sort of timeliness and geographic specificity of data, surveillance data. We've got right now, despite a huge national asthma control program, which I supported scientifically, we've got a fraction of states contributing data in a timely way about ED visits, inpatient admissions. And so I'd sit around in my office, get ready to go out and do outbreak investigations, and realize I was looking at fatality data from 2 years ago, where as from what can I do in a public health role? Very little, right? I can build maps like this that take sort of the one piece of information about an inpatient admission or an ED visit. That is the residential location, the address where somebody lives, and I can sort of choropleth it and think about this. But we know there's all kinds of small area variation in asthma, and again, after the fact and sort of not specific enough, it's just not super helpful. And then on the self-management side, also like very little progress, right? Now the kind of the trend in asthma is to give these composite questionnaires of control, which really rely on heuristics and recall. Like look at question 4, like how often in the last 4 weeks did you use your rescue inhaler? It's a question that we just know people won't be able to answer accurately. And then this kind of stuff, these pen and paper diaries that have really dominated the self-management approach to asthma for as long as I've been doing academic work on it. And what frustrated the crap out of me was seeing the digital health wave come up and just watching those pen and paper interfaces get translated into electronic format. Right? Like total failure of imagination in the use of technology and how it could be put to work to minimize the burden of managing a disease and to put us on a better path. So I built, starting in 2006, started putting electronics like chips, sensors, radios on inhaled drugs, medicines that people are carrying around and using at the time and place where they have exposures that cause symptoms. So how many people know or have some kind of chronic respiratory disease? It's pretty common, right? It's about, sort of affects every household. And I just realized that there was this opportunity to visualize day-to-day burden and management of a disease in a new way that would allow us to improve the way we're treating it from the clinical perspective, and then what we could do with public health. So this is kind of a schematic of the system. You get it. It's hopefully it's a gizmo that goes on the end of an MDI or a dry powder inhaler. The information goes into the cloud and so forth and goes into an online account, and we can kind of coach and provide guidance and feedback to people to help them achieve control of the disease. And then give it to the physicians so they can take care of big old panels of patients really efficiently. So a couple of years ago, we got approached by a new mayor of Louisville, a guy named Greg Fisher, who had brought in a fellow named Ted Smith from HHS, was really excited about the opportunity sort of being demonstrated by Todd Park and co. in the administration of open data, really thinking about ways in which data from daily life and from big infrastructures could change the way they're managing municipal problems, health, disease, you name it. But more importantly, like Louisville has just suffered perennially from poor air quality and terrible respiratory health. And these guys started to recognize that there was a really strong business disincentive for moving to relocating business to the city. And so they thought, all right, let's bring in technology. Let's think about how we can enable the citizens of Louisville. We can weaponize the citizens of Louisville with the technology that they need to do a better job managing their disease day to day. And then we can kind of build this sort of last mile of public health surveillance, get a metro health and wellness, the real-time information about where, when, among whom asthma is a problem in the community. And they can put that information to work to sort of better target and evaluate their interventions against asthma. So everybody got the scene, right? So here I am building a digital health company. I get this kind of call, like, let's do something in Louisville. Let's go with a metro approach. So we partnered with a whole bunch of people in the city, and if anything, this is really not about us. It's about kind of all the door knocking and real sort of giant effort that goes into rallying people in a community around something kind of weird, new. So Norton Healthcare, Humana's on the board, air pollution control district. Logos in a second. But then we figured out, like, okay, we want this to be everybody from the city. So we got Walgreens involved, and basically, to this day, if you wander in off the street in Louisville to fill or refill an asthma-related med, the pharmacist or pharmacy tech or whoever we'll offer you a chance to participate in the program, and we'll give you one of our kits for free and let you go out. And you have to agree that you'll at least consider sharing this information with Metro Health and Wellness in a de-identified, aggregated way, so that they can think about what the hell they're doing with asthma, how they're dealing with stationary and mobile polluting sources, and what they're doing to collectively to address the air quality. So it won an IBM Smarter Cities Award, got a lot of press, and we ended up enrolling a whole boatload of people. But this just shows you, like, it just took so much coalition building that has really paid off. But it wasn't just sort of us, like, carpet bombing Louisville with sensors. This is a photo of somebody getting signed up at one of the clinics. And I just want to spend the remaining time going over a little bit of results. First, on the clinical management side. Second, on the public health side. And I want to totally emphasize, like, very preliminary interim report from that project. So what you see is a kind of a density histogram of our ability to decrease the frequency with which people are using rescue inhalers to relieve symptoms, right? Great. Everything, kind of a horrible graph. Everything to the left of the red line is an improvement on the left side. Everything to the right of the red line in the right panel is an increase in the number of symptom or asthma-free days, right? So essentially the message is we're able to help people reduce the frequency of symptoms of asthma. Great. We doubled the number of people who had well-controlled asthma in the population in the first 30 days. So they enroll, they go through a control period. We don't give them any feedback about how they're doing or any support or reminders. Then we turn that on. We're able to make significant improvements in sort of day-to-day asthma control. And then now we can start to get into some of the public health data. So we're looking at essentially a chart here, a day-by-day chart showing the frequency of the short-acting bronchodilator use. You see all kinds of patterns that you would expect, like the September epidemic that occurs when kids go back to school. We just heard a boatload about it in the media, and start. And then so what you're seeing here, and then what we're doing now essentially as a team is starting to look at what this teaches us about where asthma is a problem and when the folks in Louisville. And this is it's not India, that's actually Indiana, thankfully. But this is a map showing where people are enrolled. So one of the things we heard early on was from skeptics was, well, you're basically just going to build a map of where people live. You're going to enroll them, and you're going to see that the place where asthma happens is actually their house. Well, turns out that's not true. And what you can see here is sort of where people got enrolled into the program. So we were able to distribute enrollment across the metro, which was. And then you can see this weird sort of hot spot in East, which actually happens to fall on the most expensive real estate in Louisville. So everybody predicted this hot spot here, which is a place called Rubber Town. It's like the easiest epidemiology you've ever done. Like, I'm studying asthma in Louisville. They're like, Maybe you should go to Rubber Town and Smoke Town. Like, thanks, I will. So, so we went there, and yes, we showed Rubber Town and Smoke Town have a problem. But we also showed that the fancy places over in the Eastern Metro were having a huge issue. Can anybody guess why? Yeah, the wind brought all the great things in Rubber Town and Smoke Town to the people in the high-priced real estate. Exactly. So this is work that I get to report, but really have zero contribution to, other than to help think about it and help try to keep people in our group motivated. It's done by Meredith Baird and Olivier Humblet, two folks out here actually now for the team. So you're starting to see some really interesting associations between some of the known criteria air pollutants. Again, we're not trying to change yet the way we think about asthma and what's driving these day-to-day symptoms. But we're simply trying to demonstrate kind of feasibility of building a bottoms-up approach to public health, right? Which so far has pretty much been top-down. So changing that, showing now, trying to convince the skeptics that we too can see things when we network and collaborate as citizens armed with this kind of technology. So Meredith and Olivier do some very elegant work that's adapted from ecology, looking at ecological niche modeling. So you can see kind of their approach, which I tried to abstract just for my own understanding. But it's basically you get these layers of geographically resolved information, and then you get the kind of temporally resolved information. You get land use, you get socioeconomic data, and essentially you can extract kind of probability estimates for observed and expected events. And then you can kind of start to model and test these things against new scenarios, like what would happen if we were able to reduce the particulate matter in Louisville by X%. What would happen to the probability distribution of asthma symptoms in Louisville if we renegotiated our polluting permit with that company? So here's some work that we just shared with the mayor's office. We're really now trying to take these results and push them into the policymaking process, not to say that this specific data set and these results should dictate, that you cut off Rubber Town, or whatever, but to say, look, we get this going, we get more people involved, we can actually start making a meaningful dent in your ability to show up at somebody's house, somebody's office and say, no, no more nitrogen dioxide coming out of your facility because it's causing actual downstream effects over, this part of the population. So this is a map showing sort of the risk of inhaler use or asthma event based on what we saw over a year of use of these. Incidentally, there's about 450 people in the. This is what happens if you were going to reduce particulate matter from by 10%. So you see kind of the area of risk shrink, right? And then you see this, the next slide, which is loading. It just shows you the area where the green kind of colors all the area of contraction where risk went down. Make sense? So, I'm really thrilled by what we're seeing here. I'm thrilled by the sustained interest of all the stakeholders, because now we can take this to payers and say, hey, look, we're bringing about real reductions in day-to-day symptoms, improvements in control. Excuse me. That nets you a whole bunch of great savings on the economic side. I can take this to Metro Health and Wellness, and we can start to talk about how you field and evaluate applied intervention into asthma. And we can take it up the mayoral food chain and into the municipality and start to think about building really data-informed kind of approaches to really practical problems that economic development folks want to address, that air pollution control wants to address, himself wants to address, and make more visible. How are we public health, and what kinds of results are we getting? So that's it for today. Love questions about the effort, if anyone has.